Hello, everyone. Welcome. We'll get started in just a moment. I see some people are coming in. Welcome. Thank you for being here and welcome to this Hoosier Extracorporeal Science Conference and NRP series brought to you by Heartbeat Perfusion Solutions. For today's discussion, we have created an amazing speaker who we're all going to learn quite a bit from. We have Velia here today. Thank you for being here.
Thank you for inviting me.
And we have 4 key objectives for today's discussion. So we'll give an introduction of how NRP works, but also compare and contrast how NRP is different than traditional methods. We'll discuss the key challenges in NRP, along with the innovations in the space and what the future of NRP looks like. Today's webinar is brought to us by Heartbeat Perfusion Solutions, which is a national provider of specialized perfusion and extracorporeal membrane oxygenation services, also known as ECMO, which is how we'll refer to it today. They offer critical support for cardiac surgeries and patients requiring advanced life support, working alongside hospitals and surgical teams to ensure optimal patient outcomes. Their services include expert staffing, equipment, and management for both long-term perfusion and ECMO needs. And today's speaker, we have Velia, who is the lead cardiovascular perfusionist and ECMO coordinator at Bufalini Hospital's ICU. She's pursuing a PhD with research focusing on extracorporeal support for cardiac and respiratory failure, cardiac arrest, and organ preservation. She's co-authored over 50 peer-reviewed papers and serves on the steering committee for the European chapter of the Extracorporeal Life Support Organization. Welcome and thank you again for being here today.
Thank you.
So what we have planned for today's webinar, we will start off with a bit of a fireside chat. So I have a number of important questions that we often get asked about NRP. So we'll start with a discussion back and forth. I'll be moderating today. My name is Sam La Liberty. And we're also going to be saving time for question Q&A. So right in front of you in Zoom, you'll probably see a chat box and you'll probably see a question Q&A box. Put any questions that you have for us as we go through the conversation, and we'll make sure we save time. So with no further ado, I think we're ready to get started. I see we have more and more people trickling in. Thank you for being here. So can you start off by just briefly explaining your role and your involvement with NRP?
So again, thank you for inviting me. I'm a perfusionist here in Italy. In Italy, we have a long history with DCD organ donation and NRP in DCD donors. And I had the honor to start working for one of the centers in the country with the largest experience in DCD organ donation. So apart from being a normal perfusionist, involved in all the conventional duties of a perfusionist, I have been involved in DCD organ donation. And with this center, I was able to increase my experience with this kind of patients and donors. So now I'm able to do research in the field because of our numbers and because of our increasing experience. And now I'm able to train other perfusionists and other members of the multidisciplinary team involved in DCD organ donation to perform at best this kind of strategies of reperfusion.
Okay, well, it's great to have your expertise here today. You're the perfect person to have this discussion. But for those of us who might be less experienced with NRP and these types of procedures, can you just share what the key components and the technologies are involved with this?
For NRP, it really depends on the strategy that you are performing. For the ones of you not experienced in DCD organ donation is this the enrollment of donors who do not undergo to the conventional neurological determination of death, but undergo to the what is called circulatory determination of death. In circulatory determination of death, we often imply this technique, this strategy of NRP. The strategy of NRP that we perform depends on the organs that we are trying to recover for that particular donor. It could be an A NRP, so abdominal NRP, or it could be a thoraco-abdominal NRP, depending from the organs, abdominal or thoraco-abdominal organs. And we mostly use something which is really similar to the devices and the circuit that we use for the conventional extracorporeal life support, so to the conventional ECMO. We need cannula to perform the extracorporeal circulation. We need a circuit, which could be a conventional ECMO circuit or could be a modified ECMO system, depending from the strategy. For abdominal NRP, a conventional ECMO circuit, it's enough. For thoraco-abdominal NRP, you mostly need to modify your ECMO system, or maybe you need to include in your ECMO system a reservoir. So you need to use what we call an hybrid ECMO system with a rigid reservoir to manage air and to manage the blood flow coming from the field and to manage the blood flow coming from the left ventricle if you are venting the ventricle. Or maybe you could use a conventional CPB circuit. So depending from the strategy, ANRP or TANRP, the devices that you are going to use are a little bit different. But again, it could be similar to what we use for ECMO. My advice, if you need to start to plan programming an NRP program at your center, is to consider using not conventional ECMO system, but short-term ECMO systems. Because the procedure, it's really short. It could be 1 hour, a couple of hours, 3 hours. So using a long-term ECMO system from an economical point of view, it's not providing you an advantage. So using a short-term ECMO system with polypropylene membrane lung, with a not so advanced biocoating, it's more than enough to provide a safe and effective procedure and to increase the use of this kind of procedure, because you are sparing resources for patient maybe needing ECMO.
Okay, and there are other organ preservation methods that exist today, right? There's cold perfusion, for example. So how does NRP compare to those more traditional methods, in particular in terms of the outcomes that you're seeing or that we could expect to see?
Okay, you do not need to compare NRP to other strategy to preserve the organs, because you could use both NRP and organ preservation strategies. NRP is what we use to avoid what we call direct procurement. So what is direct procurement? After determining the patient has death with circulatory criteria, you rush to open the abdomen or to open the chest and the abdomen to recover the organs and to provide a perfusion with a cold preservation solution to start a cold ischemic time. With NRP, we can avoid this rush because we shorten the warm ischemic time that DCD donors undergo to, and we can provide a safe environment for procurement. Because as soon as we are able to reperfuse the organs with warm oxygenated blood, you do not need to rush. You can go for a safe and an effective procurement. You can evaluate the organs, you can evaluate the blood, you can evaluate the function of the organs, you can evaluate the organs from a microscopical point of view, you can eventually do biopsy, so evaluate the organs from a microscopical point of view, and then at the end, you can decide if you can recover the organs or not. If you decide that you can recover the organs, then you should decide if performing ex vivo machine perfusion, And if you decide to perform ex vivo machine perfusion, you can decide to perform hypothermic oxygenated perfusion or normothermic oxygenated ex vivo perfusion, or maybe you can decide to perform direct transplantation. This depends on the condition of the organs, on the length of the warm ischemic time before procurement, and depends on the on your program, because maybe you have a recipient in the site where you perform the NRP, or maybe you have a recipient far away and you need to preserve the organs for a prolonged period. So NRP is not something that we use to avoid the other strategy. It's something that we could use with the other strategy, depending from the situation. So you could use both NRP and ex vivo machine perfusion, or you could use only NRP.
So it's not
but
necessarily
NRP compare to direct procurement rather than comparing with ex vivo machine perfusion.
And you mentioned briefly about the shorter time frame. So can you walk us through the process of actually preparing a donor for NRP? So what would be the necessary equipment? What time frames would be required for this?
Again, this is not an easy question because we have different categories of DCD organ donors. We classify DCD organ donors mostly with the most commonly used classification, which is the modified Maastricht classification. And we have 4 categories of DCD donors. In some countries, we have additional categories, but the most commonly used is a 4 categories classification. And we can enroll all of these donors, but the most commonly enrolled donors are DCD2 and DCD3. DCD2 are uncontrolled donors. What is happening? You have a cardiac arrest, intra-hospital or out of hospital, but is a witness cardiac arrest. So you're able to know the length of this cardiac arrest, but you do not control the cardiac arrest process, and you do not know anything maybe about the donor before the cardiac arrest. So DCD2 organ donors are uncontrolled donors. DCD3 organ donors, the most commonly enrolled DCD organ donors, are controlled donors. You have patients in the ICU, in the emergency department, or in any other kind of department, suffering from maybe a cardiac arrest, but recovering from cardiac arrest, but experiencing a neurological damage, or maybe patients suffering a neurological damage not related to a previous cardiac arrest, and you define that persisting in treating this patient is not in the best interest of the patient. Or maybe the family asks for interrupting life support, or maybe the patient, when he was able to do, stated that he doesn't want any kind of advanced treatment. So you can interrupt life-sustaining treatment, and then the patient develop a cardiac arrest. These DCD3 organ donors are controlled donors because you can control the cardiac arrest. You can monitor the patient before the death. You can define the timing. You can prepare the organ donation, and you know everything about this patient, everything about his health, everything about his willingness to become a donor. So it's a really controlled situation. So these are the best donors for DCD organ donation. And this is the easiest topic to discuss about because you can control the timing. So you can assess anything about the donor. You can define in advance the potentially associated risk with the DCD organ donation in that particular patient. And you can organize the organ procurement, and you can organize the NRP procedure. No matter what, with both DCD2 and DCD3, you have a period of suffering for the organs, which is named warm ischemia. Why? Because before the cardiac arrest, you could have hypotension and desaturation. Then you have a cardiac arrest, and then you have asystole. So again, ischemia for the organs. And this, it's a suffering for the organs. Why? Because the organs are in a normothermic environment before the death, but these are not perfused or are poorly perfused before cardiac arrest, and they could suffer. And this is the reason why introducing NRP in DCD organ donation can shorten this period of warm ischemia, because instead of going for direct procurement, so instead for going for additional warm ischemia, you can reperfuse the organs with warm oxygenated blood, shortening the warm ischemic time. About the timing, it's a difficult question, not only for the different categories of DCD organ donors, but also because we have a different legislation out of there. Country by country, you need to respect different laws, and the timing for declaring the patient as dead with circulatory criteria is really different in different countries. We have this rule, which is the dead donor rule, stating that you can recover vital organs until the patient is declared as dead. And how you can declare the patient as dead with circulatory criteria? You need to wait for cardiac arrest. Then you need to stop any kind of supporting treatment, and you need to observe the donor. You need to observe for the lack of cardiac activity for a number of minutes. And this period is called no-touch time. You can touch the donor. You can perform anything aimed at recovering organs in this observation period, which is the no-touch time. The no-touch time is really variable. We have countries waiting for 90 seconds or 2 minutes after cardiac arrest. We have countries waiting for 5, 10, 20, 30 minutes after cardiac arrest. And this period is a warm ischemic period. Until you're able to reperfuse the organ, this period is a warm ischemic period. But you need to respect your law. So no matter the countries where you live and when you work, you need to wait for this period of time before performing NRP. Another problem with discussing about the timing of DCD organ donation is that we have this different regulation also for what we call antemortem intervention, which is the intervention that you could perform before the death to be able to provide an RP after the death. In some countries, you can do anything. You need to perform cannulation, circuit connection, and reperfusion after the death. In other countries, you can insert the cannula and connect the circuit before the death, but you can start reperfusion. In some other countries, like mine, for example, you can't insert the cannula, but you can prepare the vessels, inserting guide wires and exposing the vessel, if you wish, before the death. And then you need to perform cannulation after the death and start reperfusing after the death. So it's difficult to talk about timing because you need to consider in which country are you living, and you need obviously to respect all the laws of your country in terms of respecting the no-touch time, respecting the antemortem intervention that you could perform. But no matter what, reperfusion could only start after the death. This is true for all the countries where DCD organ donation and NRP are legal.
Okay, so
not sure if this was answering to your question.
Absolutely, yeah.
Because I do not have a specific answer.
It's not like you can give a clear answer when it differs so much. We have a global audience tuning in to a webinar like this, and so it really depends on where someone is performing the procedure. So with all that in mind, it does sound like it's still quite promising, the innovation that we're seeing here. What have been the most notable clinical benefits of using NRP compared to traditional methods? And I know you've touched on a few, but how else would you like to add to that?
We start to develop a real interest for NRP organ donation in countries where the no-touch time is long. Why? Because in this country, if you do not go for NRP, the warm ischemic time is so long that DCD organ donation is not feasible. So we started implementing this kind of procedure in these countries more and more. And we start noticing that the results were really good in a selected population. Then we start implementing NRP not only in a selected population, potentially young and healthy, but also in older donors and not so healthy donors. At the moment, for example, in my country, we are enrolling a high number of really old DCD organ donors, above 80, above 85 years old. Obviously, we are able only to retrieve the liver in these donors, but it's really promising because we can enroll more and more donors. And starting with the observation that we were performing in these countries, other countries normally going for direct procurement because they have a really short no-touch time, started using NRP. Because with NRP, DCD organ donation, it's easier and maybe it could be less expensive. Why? Because you need to perform NRP. But if you perform NRP, sometimes you're able to assess the quality of the organs in such a way that you could avoid other strategies, or maybe you can shorter other strategies. So it could be an alternative sometimes to other strategies, or it could be an addition to other strategies, potentially making you able to enroll donors that you were going to lose without NRP. So NRP, it's increasingly used also in countries with shorter no-touch time that traditionally went for direct procurement.
No, that's very promising. So thanks for sharing that with us. You mentioned the challenge with operating this procedure really can depend on what country you're in. What are some of the other challenges you encounter when implementing NRP?
Okay, we should mention that NRP, it's a normothermic perfusion of a part of the body. The air in NRP, the R in NRP is regional, normothermic regional perfusion, because we need to reperfuse only a part of the body, which could be the abdomen, as said at the beginning, or the thorax and the abdomen. What we are not reperfusing. When we do NRP, we do not want to reperfuse the coronary arteries and the cerebral arteries. So we do not want to reperfuse the brain, and we do not want to reperfuse the heart, because if you reperfuse the heart with warm oxygenated blood, the heart could start beating and then could start reperfusing the brain, which is what we do not want for an ethical problem. With thorac-abdominal NRP, we want to reperfuse the thorax and the abdomen, so we need to prevent cerebral circulation. So we need to find the strategy to prevent cerebral perfusion in TA-NRP and to prevent coronary and cerebral reperfusion in ANRP. This strategy could be different because, again, country by country, you need to follow the law because the law says how you could prevent cerebral perfusion. For ANRP, you could use a surgical clamp to clamp the descending thoracic aorta above the diaphragm, so above the celiac trunk, or you could use an endovascular balloon occlusion, again, of the descending thoracic aorta above the diaphragm. In some countries, you can perform what you like. In some other countries, you need to go for surgical clamping, for example. For thorac-abdominal NRP, you need to clamp the neck vessels. So the left carotid artery, the subclavian artery, the left subclavian artery, and the brachiocephalic trunk to prevent cerebral perfusion. But this is not enough in other countries, saying that you should not only clamp these vessels, but also cut these vessels and potentially venting these vessels to prevent any form of reperfusion through collaterals that you could have with thorac-abdominal NRP. So this is another potential challenge because you need to perform this regionalization of the flow, and you need to be sure that the flow, the cerebral flow is prevented throughout your procedure. So you need to monitor that you do not have any kind of flow during the procedure. This is another potential challenge.
What about the limitations when we think about certain patient populations or certain organ types? Are there any noteworthy limitations there when it comes to the application of NRP?
About the patient population, we at the moment enroll any kind of potential donor. But again, in some countries, it's easier. In some other countries, it's not so easy. With older donors, a potential issue could be having a difficult cannulation, particularly if you go for uncontrolled donors, because maybe if you enroll aging patient, cannulation becomes much more difficult. For example, in a patient of 80, 85 years old, you maybe have a atherosclerotic disease, so cannulating a couple of vessels could be not so easy, particularly if you need to go fast to shorten worm ischemia. And the same could be true for pediatric patient. The experience that we have for pediatric population, it's really, really limited. Because normally neonatal and pediatric patient develop neurological criteria for determination of that. So there is really few published experience involving a pediatric patient, but we have something particularly from Spain, and it could be feasible. Again, cannulation of pediatric patient, it's much more difficult compared to cannulation of adult patient, particularly if you need to rush. But as it is feasible for ECMO, it's also feasible for NRP if you have the criteria and if you are able to respect the law also for this kind of patients. Not sure if this is the answer that you were looking for.
Yeah, and for those who have just joined, we are going to save some time for audience Q&A, so feel free to put any questions you have in the chat or in the Q&A box. So we've talked quite a bit about the maybe like legal and compliance challenges that come up when you operate this procedure country by country, but what about ethical considerations? Are there any ethical considerations that we need to address when using NRP as it relates to the donor and circulatory death?
The major issue with the DCD organ donation is being able to respect the no-touch time. So being able to respect the dead donor rule, waiting for the patient to be declared dead before starting NRP, obviously, without any rush. In my country, for example, we need to wait for 20 minutes of no touch, but it's not only 20 minutes because it's 20 minutes of asystolic lack of cardiac activity. So we need to wait for having 20 minutes of continuous cardiac arrest from an electrophysiological point of view. And if you are experienced with this kind of patient population, sometimes before cardiac arrest, we have a prolonged pulseless electrical activity. So we maybe have a lot of minutes of pulseless electrical activity, and then the asystole. And then when we develop the asystole, we need to wait for 20 minutes. But anyway, it is feasible also in my country to recover the abdominal organs and also the heart and the lungs, no matter what. So you do not need to see the no-touch time as a limitation. You can be able to recover the organs fully respecting the law, fully respecting the dead donor rule, and fully respecting the no-touch time. So this, for me, it's not a major ethical issue because we can respect this regulation without impairing DCD organ donation, absolutely. The most debated aspect from an ethical point of view of DCD organ donation is the potential for cerebral perfusion. Because there is the potential for cerebral perfusion also if you fully comply with the regulation of clamping the abdominal aorta, the descending thoracic aorta for abdominal NRP, and the regulation for clamping the neck vessels for thoracoabdominal NRP, because we can have anomalies, we can have collaterals, so we can potentially have a limited amount of flow through the brain. This is the ethical issue that impair the implementation of NRP in some countries, and we limit the implementation of NRP in other countries. In some countries, it is not legal to perform NRP. In other countries, it's legal to perform abdominal NRP, but not thoracoabdominal NRP unless you're running a specific trial, so unless you're doing research on this. But you need to consider that even if you could have a limited amount of flow from collaterals during thoracoabdominal NRP, if you perform, like we do, neurological monitoring, you can see that this limited flow is not able to really reperfuse the brain. Particularly if you enroll the CD3 organ donors, so donors undergoing a brain damage before starting with withdrawal of life-sustaining treatment and then undergoing another additional brain damage during withdrawal of life-sustaining treatment with hypotension and desaturation and during the period of cardiac arrest, it's unfeasible that this limited amount of flow in a really damaged brain with a really high cerebral pressure, I mean, intracranial pressure, could be able to reperfuse the brain and resuscitate the brain. This is what some people say, you are resuscitating the brain. No, it is not feasible to resuscitate the brain after declaration of death. We are reperfusing a body. We are reperfusing, it's not a good term, but we are reperfusing a cadaver. And we are doing our best to fulfill the willingness of the patient to become a donor. So we are respecting the willingness of the patient. We are respecting the family of the patient and their desire to have their loved one becoming a donor. So we are not wasting their organs. At the center of our activities, there is no the DCD program, there is no DNRP, there is no our desire to procure the organs to save the life of recipients, but there is our donors. This is the center of the program, our donors and our the gift that they do to the society, deciding to become donors, not only after the conventional neurological determination of death, but also after circulatory determination of death. So we are respecting the donor with NRP program and with DCD organ donation.
Absolutely. And I appreciate your candidness at really sharing your opinion on some of these more controversial ethical debates and just kind of understanding where you stand and being quite open about that. I think that's really helpful. We have a great question from the audience from David, who is seeing lots of NRP done without a method to rewarm. So effectively hypothermic regional perfusion. So is there any data to support normothermic versus hypothermic regional perfusion?
Okay, this is really a really good question. Mm-hmm. So the N in NRP is normothermic. So at the origin, the idea was to providing a physiological environment. So to reproduce the in vivo situation before the death, because if you rewarm the organs, you can restore some enzymatic process, you can potentially recondition the organs, and these organs suffered a damage from warm ischemia. So during NRP, you can not only provide a safe environment for procurement, but potentially you can try to recondition the organs and start the healing process. So this normothermia was intentional. And if you look at the guidelines that we actually have for NRP organ donation, mostly focused on ANRP from the European Society of Organ Transplantation, which were published at the end of 2021, it is said that the basic components of the device that you should use for NRP are a centrifugal pump, a membran lung, and an heater unit. So you need to warm up the blood. But in recent years, we have a lot of evidence, not from NRP, but from ex vivo machine perfusion that seems favor hypothermic oxygenated perfusion, not normothermic oxygenated perfusion for ex vivo machine perfusion. It's not really high quality evidence, but it's a lot of evidence accumulating. So some people start saying, okay, maybe we can try also for NRP, going not for normothermia, but for subnormothermia, so avoiding using an ITER unit. This could make life easier for people running mobile NRP programs and maybe could have a different outcome. But at the moment, we do not have evidence about NRP. So we need a lot of data. If you are running NRP, if you are starting a program, please collect data and do research on NRP because the number of procedures are increasing. But compared to ECMO, compared to CPB, these procedures are really, really limited. So we need a lot of data. So please collect data, share data, and research on this because we need more evidence. But this was a really good question.
Mm-hmm. Yeah, thank you, David. And absolutely, it's still so new. So the more we can work together and share our learnings, it'll only advance the space, which I think is a good closing question is about the future of NRP. So I think a lot of today's discussion has really been revolved around how it stands today. What are the limitations? What are some of the clinical benefits that are notable, that are really working and promising? But where do you see the future of NRP going in the context of organ transplantation?
I think that is going to grow.
Okay.
Again, we have a lot of research ongoing. And I hope that this research is going to show that we do not have any form of cerebral perfusion during TA-NRP and during NRP with the techniques that we are using. So this could prompt other countries actually not doing NRP to do NRP and to involve more and more centers in this kind of procedure. We are going to have an increasing number of procedures also because some producers are starting inserting on the market devices specifically thought for NRP and for short-term ECMO. So this increases the feasibility of this kind of support because cut a lot the investment that you need to do to perform this kind of procedure. And this could be important, particularly in countries with a limited amount of resource available for this kind of programs. And so I think that with the research which is ongoing, the number of procedures is going to grow, definitely. And the number of countries allowing NRP and DCD organ donation is going to grow.
Amazing. Well, thank you so much for being here. And thank you everyone who tuned in. This is our first event, but we have 5 upcoming over the next month or so. So we'll be emailing details to the next event to everyone, as well as posting on social media. You can also learn more about the webinar sponsor today, Heartbeat Perfusion Solutions, by visiting their website. So on that note, we'll wrap up here. Thank you again, everyone, and we hope to see you at the next one.
Thank you. Thank you again for inviting me.
Bye.
Bye.